This is the subject, our subject now. It's about women and heart disease. I'm Dr. Nagi Azzi from Lebanon, clinical and interventional cardiologist. So this is our subject for today. The heart disease in women. The magnitude of the problem, it's, are you hearing well? My voice is clear? Okay. It's a leading cause of death, mostly due to ischemic heart disease and stroke. Angina is a common presentation of coronary heart disease in women and in men. The ischemic heart disease in women versus men is present at older age. The mortality ratio is 4 to 5 between ages 30 and 64 years, and the ratio is 2 thereafter, which means between 65 and 89. And this ischemic heart disease is less likely to be diagnosed and treated in women. And we have a higher cardiovascular mortality because of heavier risk factor burden, more involvements in inflammatory factors, smaller coronary vessel size, and the treatment of diabetes, which usually less positive. And the estimated annual cost for cardiovascular disease in men and women is about $400 billion in the United States. Now, the prevalence of cardiovascular disease in adults by age and sex. So as we see in this American Heart Association study, in 2016, we see that in the age group 20 to 39 years old, the men are the prevalence, the percent of population, the prevalence is 11.9 in men and 10% in women. This difference grows bigger between ages 40 and 59 in men, 40.5 towards versus 35.5. It shrinks a little bit between ages 60 and 79 because of the occurrence of menopause. And afterwards, after age 80s, the ladies, the women percentage, the prevalence of cardiovascular disease become a little bit superior to men. Okay. And also in the lower slide, the lower diagram, we see also that with age, the proportion of women with cardiovascular disease increases progressively with age groups. Now, cardiovascular disease and other causes of death. More than 1 in 4 women will die of heart disease, more than 1 in heart disease. And 1 in 30 women will die of breast cancer. It's approximately 8 times more than breast cancer. So in this diagram, we see that for the death rate for white and black female, we see that it's 101 in white females towards 130 in the black females, which is much superior to stroke. 41.1 in white females towards comparing to 57 per 1,000 the death rate in black women and black females. And the lung cancer is less, and the breast cancer is 22.9 in whites and 31.6 in black females. This is from the American Heart Association 2010. Now, as we see in this, also the curves, this we see that in this study done between 1980 and 2009, cardiovascular disease deaths in the United States, we saw that before approximately 1984, 1985, the percentage of deaths was superior in men. And afterwards, if we say it's progressively declined in men, but it stayed horizontal or the same, and even at towards 2005, it increased 2006, 2000, and afterwards, when there was this, there was this initiative. And we took into consideration the higher women deaths. There was this initiative to reduce the mortality. And after we see the curve of women joining the curve of the man, the death rate, until our present date. This is the effort that has been done in that regard. Now, gender differences in sudden cardiac death, symptoms, and quality of life. The sudden cardiac death before arrival at the hospital, it's 42% in women, 25% in men, which reflects the misdiagnosis and the and other reasons that we will see further. The symptomatic women versus men more often have recurrent symptoms requiring hospitalization, recurrent symptoms, lower ratings of general well-being, and limitation in ability to perform activities of daily living. Now, the outcome of coronary heart disease, the survivors of acute coronary syndrome have 1.5 to 15 times greater risk of illness and death than general population. And within 6 years of MI, we have a recurrent MI 35% in 35% of women compared to 18% of men, which is practically double of the recurrent MI. Sudden cardiac death, it's practically the same, 6 for men, 7 for women. Heart failure is more than twice in women, heart failure after 6 years of MI. So we have to note this. Stroke is a little bit more in women. Now, the causes of MI, acute MI in young women include plaque-related MI, microvascular dysfunction or vasospasm, and spontaneous coronary artery dissection. The ACC National Cardiovascular Data Registry for in-hospital mortality in patients with chest pain. This is a study that was done around in 2010, and which studied the hospital mortality after coronary angiography. And we found across all the subgroups, the ethnic groups, that women have a higher mortality, and this mortality grows significant in white women, maybe because of the bigger number. This is in the United States, 338,000 number of white women. The difference of women towards men is higher of mortality. It's 1.67 to 2-fold higher than white men. Now, the presentation, evaluation and treatment, benefits and risks about the women and heart disease. We want to talk about the VIRGO study. The VIRGO study studies the gender differences in symptom presentation and perception. It studied the younger patients with MI from 104 US hospitals between 2008 and 2012, the age between 18 and 55 years old. There was 2/1 female-to-male enrollment. So 90% of men, 87% of women presented with chest pain, pressure, tightness, or discomfort. Women presented more additional symptoms. More women waited more than 1 day to seek care than men. This is very important. It's significantly superior. And at time of hospitalization, 24% of women said healthcare provider did not think symptoms were heart-related, compared with 12% of men. It was also statistically significant. So the symptoms presentation on the right diagram, we have it was for man, the chest pain or discomfort was significantly superior in man. However, the atypical, the symptom additional symptoms were more frequent in women: radiating pain, indigestion, nausea, shortness of breath, weakness, fatigue, palpitation, especially, which was much more frequent in women with acute coronary syndrome. So now the Women Ischemia Syndrome study, the National Heart, Lungs, and Blood Institute sponsored 4-center observational study in women more than 18 years of age, ongoing clinically ordered coronary angiography for suspected myocardial ischemia. The number was 936. The women had the myocardial ischemia at non-invasive testing. The exclusion criteria in this study were emergency referral, pregnancy, cardiomyopathy, New York Heart Association class 4, recent acute MI or unstable angina, recent coronary vascularization, significant valvular or congenital heart disease, any contraindication to provocative myocardial stress testing for sure, and any condition likely to affect study retention. The objective was in the WISE study to optimize symptom evaluation and diagnostic testing for ischemic heart disease, to explore mechanism for symptoms and myocardial ischemia in the absence of epicardial coronary artery stenosis, and to evaluate the influence of reproductive hormones on symptoms and diagnostic test response. So what were the findings of the WISE study? For the angina, the conclusions were overall, typical angina is not a good diagnostic indicator of CAD in women. And after age 55, classic angina classification is moderately predictive of coronary artery disease. There was a sub-study in the WISE study, sub-study concerning the magnetic resonance spectroscopy results, which studied the coronary metabolic dysfunction. They found that when there is no CAD and normal MRS, the freedom from event was practically 90%. Whereas when there was CAD, the freedom from event was around 50%. And we see here that when there is no CAD with abnormal MRS or magnetic resonance spectrum result, so it's practically similar. The freedom from event, it's practically similar to the women with CAD, which has to be noted, and the P is significant. This sub-study is from 2004 circulation. Now, for the conclusion of this spectroscopy, abnormal MRI spectroscopy results are found in about 20% of women with chest pain but no CAD. This abnormality is predictive of cardiovascular event, ischemia, related hospitalization. Now, we tried to find, there is this notion of hypoestrogenemia and CAD. We found that hypoestrogenemia was among the independent predictor of CAD. It predicts 7.4 times the occurrence of CAD. We have the aspirin use, 7.6, which is very close, and the ATP or the Framingham heart study risk more than 3%, 8.3% also. But the hypoestrogenemia has to be underlined. Now the independent predictors of hypoestrogenemia, the study found that anti-anxiolytic anxiety medications have a hazard ratio of 4.6, and also the presence of diabetes has a hazard ratio of 3.5 for the presence of hypoestrogenemia. So in hypoestrogenemia and CAD, the premenopausal women with obstructive CAD are highly likely to have hypothalamic hypoestrogenemia, and this condition is related to anxiety as suggested by use of anti-anxiety medication and diabetes. So the summary of key findings were that a diagnostic approach, that the chest pain is not a good indicator of CAD in women. Myocardial ischemia, the coronary metabolic dysfunction occurs in about 20% of women with chest pain and no CAD, and it is highly predictive of cardiovascular event in these women. The influence of hormone and geographic premenopausal women with CAD are highly likely to have hypothalamic hypoestrogenemia. Now, this study, after 10 years, there was an analysis in the circulation, the 2017, at 10 years, that found that significant independent predictors of all-cause mortality in WISE study, the obstructive CAD was the hazard ratio 2.13, the history of diabetes mellitus 2.02, predictive of all-cause mortality. Then we have the history of smoking 197, hypertension 165, triglyceride 139, and so on, GFR, and age 102, not high, a little bit. So artery disease, if there is no CAD, the mortality risk is around let's say the percentage of surviving, it's around 90%. When there is minimal CAD, it's around 85%, and when there is obstructive CAD at 10 years, they have around 65%. So this study, what the Y study adds, the study enumerates a 20% rate of mortality within 10 years among women referred for coronary angiography for signs and symptoms of ischemia, 20% rate of mortality within 10 years. It demonstrates the elevated risk of all-cause mortality among women with signs of symptoms of ischemia, but without obstructive coronary artery disease, 13%, as compared with a nationally representative of cohort of American women of approximately the same age during the same period, 2.8. It provides evidence that most of the predictors of mortality risk factor can be modified by current therapy, supporting the development of clinical trials in women symptomatic of ischemic heart disease, even in the absence of obstructive coronary artery disease. This is at 10 years of the WISE study. Now, the evolving understanding of angina in women, the typical versus atypical angina diagnosis by gender. This is a study by Duke University concerning 3,225 patients for evaluation of chest pain with median in patients with median of 5 episodes of chest pain weekly. They found that in males, typical angina was about 55% and atypical was 35%. And in women, it was the typical angina was only 25%, which is half of the male, and the atypical angina was 53%. And women has more angina equivalents, as we said: fatigue, lightheadedness, weakness, diaphoresis, shortness of breath, nausea, indigestion. Coronary patient with angina rates their quality of life lower than those without angina. Now we have to talk about the novel risk factors in women. The traditional risk factors and the Framingham risk score may underestimate risk in women. The novel risk markers that may improve risk detection, we have abdominal obesity, metabolic syndrome, including at least 3 of the following: insulin resistance, dyslipidemia, elevated triglycerides, low HDL cholesterol, hypertension, or abdominal obesity. Other novel risk marker, low estrogen level, as we talked before, elevated testosterone level and the polycystic ovary syndrome, which is well known, elevated C-reactive protein. And in postmenopause, we have a clustering of risk factors in common. The clustering of risk factor is common: obesity, hypertension, dyslipidemia. And these risk factors also predict early menopause because metabolic and hemostatic factors may be sensitive to hormonal variation during the early perimenopausal transition. Now, there was in this study in 2007 by Heartcare on 100,000 women, there was this reclassification of risk in women using the Reynolds risk score. The Reynolds risk score, because those 100,000 women with intermediate cardiovascular risk were classified according to the Framingham, the ATP3 covariates. They found that we have 80% of these women have 5 to less than 10% cardiovascular risk, and 20% with 10 to less than 20% cardiovascular risk. But when we reclassify these patients according to 10 years cardiovascular risk using Reynolds risk score, we found that among the 5 to 10%, we have 15.9 over them found out to be at low risk, less than 5%. 55.7 had a low to moderate risk between 5 and 10%, and 26 or 27% have effectively more than 10% or moderate to high risk of cardiovascular disease. And in the other subgroup of 20%, there was subdivided using the Reynolds. We found they found to have 3.8% who had less than 5% risk, around 20% between 5 and 10%, 55% who had only who had the risk that was evaluated by the ATP3, and more than 21.2% to have had more than 20% cardiovascular risk. This is the ATP3 that studied the age, systolic blood pressure, total cholesterol, HDL cholesterol, smoking status, that gives the score, the risk on over 10 years. And this is when we applied to women with intermediate risk, the Reynolds score. When compared to the Framingham risk score, use of the Reynolds score resulted in risk reclassification in more than 40% of intermediate Framingham risk score women. So in intermediate risk women, we have to use the Reynolds risk score to reclassify them to better assess their cardiovascular risk. Now, the assessment of myocardial ischemia and obstructive coronary disease in women. When there is symptoms suggestive of myocardial ischemia, women, as we spoke before, that women have lower rates of obstructive coronary artery disease as angiography. There was this early work by Diamond and Forrester, in 1979, that said that women with typical or atypical chest pain have calculated obstructive coronary artery disease probability substantially less than men. And typical exertional angina in a 55-year-old man has a probability of obstructive CAD of approximately 90% as compared with a wide range from 55 to 90% for a 55-year-old woman. So there is really variability in women concerning the typical angina. And this does not address angina equivalents that are more frequent in women. Chest pain symptoms are less accurate and less precise predictor of obstructive CAD in women. Now, the gender differences in ischemic heart disease, we have the structural features, the micro and micro vessels. We have a smaller size of vessel, increased stiffness, fibrosis, remodeling, more diffuse disease in women, more plaque erosion versus rupture, microemboli, rarefaction, dropout, disarray, etc. Considering the functional features, we have more endothelial dysfunction, more smooth muscle dysfunction, like we have Raynaud disease, migraine, coronary artery spasm, which is significantly superior, more frequent in women. And we have the inflammation, the plasma markers, vasculitis, which is more frequent in women, Takayasu, rheumatoid arthritis, systemic lupus erythematosus, central nervous system vasculitis, giant cell vasculitis, etc. So they are in higher frequencies. Now, there is this model from show in American Journal of Cardiology 2009, the model of microvascular angina in women. We have the sex-specific precursors, the polycystic ovary syndrome, hypoestrogenemia, menopause, that lead to hormonal alteration coupled with pro-atherogenic factors like hyperlipidemia, hypertension, smoking, metabolic dysfunction, inflammation, which lead to provasculopathy. And we have in women accelerating factors like early menopause and risk factor clustering, which lead to microvascular dysfunction, like we see in this angiogram, microvascular dysfunctions that lead to subendocardial or epicardial ischemia, and also symptomatic-wise, vascular dysfunction symptoms, atypical symptoms, including prolonged symptom at rest, shortness of breath, unusual fatigue, and more frequent pattern. So this model provides a rationale for why current approaches for detection of focal obstructive coronary lesion are less effective in women with a greater prevalence of non-obstructive CAD. Now, overarching working model of ischemic heart disease pathophysiology in women from the same study. from the same study. There is this, we have to minimize something in the screen that, okay. We have, like we said before, postmenopause, hypoestrogenemia, polycystic ovary syndrome, visceral obesity, which leads in reduction in estradiol, which leads to hypertension, obesity, hyperlipidemia. It interacts with other risk factors, and it also it's causal factor. And in an inflammatory milieu, especially in the presence of autoimmune disease, it leads to symptomatic manifestation, which begin by normal artery and abnormal microvascular function. So we have this, like we say, this abnormal coronary reactivity, endothelial dysfunction, decreased the perfusion, metabolic changes, and the positive coronary remodeling with increased wall thickness, plaque erosion, distal embolization. So after we have this microvascular dysfunction, we have it may evolve to subclinical atherosclerosis and later to obstructive CAD. Okay, so it's a progressive manifestation of ischemic heart disease. Okay, now this is a schematic of mixed segmental diffuse narrowing that we see here the difference in the number A picture image. We have a predominant more severe single segmental stenosis with less diffuse narrowing, suitable for angioplasty or bypass. This is commonly found in men. And in B picture, we have a predominantly diffuse disease or multiple stenosis with less segmental narrowing, not appropriate for angioplasty or bypass surgery. And this is more frequent in women. It's more deceiving in women, the revascularization, because of this pattern that we talked about. Now, we have then this in women, the plaque erosion and outward positive remodeling. Plaque erosion and the thrombus formation are 2 times likely in women. Men have more plaque rupture, not plaque erosion. We have also outward or positive remodeling, atherosclerotic lesion, which protrudes outwards and impinging on the lumen. The combination of smaller arterial size and more prominent positive remodeling may lead to a greater role of microvascular dysfunction in ischemic heart disease in women compared to men. So now, patients with obstructive CAD who underwent simultaneous IVUS and coronary reactivity assessment found out through IVUS studies that men have a greater atheroma burden and more diffuse epicardial endothelial function, while women have more disease in the microcirculation. So the term ischemic heart disease would be more specific to women rather than CAD or CHD, coronary artery disease or coronary heart disease. This paradoxical difference where women have lower rates of anatomical CAD, but more symptoms, more ischemia, and outcomes appear linked to coronary reactivity, which includes microvascular dysfunction. And also in women, we have relatively higher CAD healthcare costs incurred in women where resource consumption patterns are characterized by more frequent diagnosis of angina, more office visits and hospitalization, higher MI mortality, and higher rates of heart failure hospitalization. So the healthcare costs are increased. Now, the focus on women, defining a woman risk status and then improving adherence to preventive lifestyle behaviors is the most effective way to lower coronary vascular disease in women. This is from Wenger in 2011. The ideal health behavior such as body mass index less than 25 kilogram per meter square, waist size less than 35 inch, physical activity at goal level, following DASH diet, cholesterol less than 200 milligram per deciliter, blood glucose less than 100 milligram per deciliter. From the American Heart Association, the guidelines, the women at risk who have more than major risk factors are the women with cigarette smoking, those who have more than systolic more than 120, diastolic blood pressure more than 80, or treated hypertension, of course. a total cholesterol more than 200, the HDL cholesterol, less than 50, or treated for dyslipidemia, obesity, especially central adiposity, poor diet, physical inactivity, family history of premature CVD occurring at first degree relative in men less than 55 or in women less than 65, the presence of metabolic syndrome, like we said, the evidence of advanced subclinical atherosclerosis, coronary calcification, carotid plaque, or thickened intima media thickness, poor exercise capacity on treadmill or abnormal heart rate recovery after stopping exercise, systemic autoimmune collagen vascular disease, which is more frequent in women, so lupus, rheumatoid arthritis, and history of preeclampsia, gestational diabetes, or pregnancy-induced hypertension. Now, so the female-specific issue, we have gender differences in cardiovascular risk factors, in tobacco, in diabetes and metabolic syndrome, dyslipidemia, hypertension, fitness. There are gender differences. And autoimmune diseases are more present with increased cardiovascular risk, like we said, rheumatoid arthritis, systemic lupus erythematosus. We have female-specific issues that contribute: pregnancy-induced hypertension, preeclampsia, gestational diabetes, and polycystic ovary syndrome. And there are other issues related to women, which are breast cancer, therapy effects, and chest radiation. Now, counseling our women, the recommended counseling our women, recommended lifestyle changes for all women. We have to counsel for smoking cessation and avoidance of secondhand smoke, of course, physical activity, which means moderate activity at least 6 to 7 days a week, with strength training 2 times a week, DASH-like, low sodium diet, weight management. Now the 2011 guidelines shifted from evidence-based to evidence-based, effectiveness-based criteria. So it derives from the benefits and risk observed in clinical practice, and the therapies that may have potential benefit. For example, we have to screen for depression, which indirectly may impact cardiovascular disease through adherence to prevention therapy and other mechanisms. So screening for depression is important in women. Acknowledgement that 10-year risk is not efficacious in women. We saw the Reynolds scores that we have to do in intermediate risk patient, to do a two times score to assess the real risk. Now, this same guidelines, we have to have a medical study, the search for symptom of cardiovascular disease, like we say, depression screening, physical examination, laboratory tests, including fasting lipoproteins and glucose, the Framingham Hill risk assessment, if no cardiovascular disease or diabetes. So we implement in women class 1 lifestyle recommendations: smoking cessation, that's DASH-like diet, regular physical activity, weight management. And we ask, is the woman at high risk for cardiovascular disease? She has a clinically established coronary heart disease, cerebrovascular disease, peripheral abdominal aortic aneurysms, diabetes mellitus, chronic kidney disease? If yes, so we have to control with medication, beta blocker, angiotensin, LDL lowering therapy, blood pressure control, and offshore refer to cardiac rehabilitation. And if no high risk for cardiovascular, and also like we say, we have to, when there is high risk of cardiovascular disease, we have to search for LDL less than 70, LDL cholesterol, and no LDL lowering therapy less than 130. Okay, glycemic control in diabetics, aspirin, antiplatelet agents, and omega-3 fatty acids. And if no high risk for cardiovascular disease, we search for blood pressure control. The LDL is then, if there is no high risk, the LDL target is if LDL more than 190, we treat with statins, and afterwards, and we consider a class 2 recommendation, a treatment for high LDL and triglycerides with aspirin, the aspirin treatment. And if there is history of paroxysmal atrial fibrillation in women, we implement class 1 recommendation, warfarin or aspirin or dabigatran that my previous colleague talked about. Okay, this is from the guidelines of 2011 American Heart Association. Now, targeting women throughout the lifespan. Premenopausal 20 to 35, perimenopausal 35-50, postmenopausal more than 50. In the premenopausal, we have to know heart disease is still the second most common non-obstetrical cause of maternal mortality. We have to do the initial assessment, a detailed medical and pregnancy complication history. The pregnancy is considered as an early stress test. It's a unique opportunity to assess lifetime cardiovascular risk. We call it the metabolic syndrome of pregnancy. And especially if the patient had preeclampsia. This is a particular situation when we have we have to do a postpartum referral for cardiovascular risk assessment. So pregnancy, a stress test for life. In fact, indeed, pregnancy stresses maternal carbohydrate, lipid, inflammatory pathways, vascular function. It unmasks underlying metabolic vascular disease. Pregnancy is a screen for later hypertension and diabetes. Preeclampsia induces damage to vascular endothelium, and it's a pathway for microvascular dysfunction later in life. Preeclampsia triggers inflammatory autoimmune responses. How should eclampsia hypertensive disorder be incorporated in cardiovascular assessment for women? So hypertensive disorder of pregnancy and subsequent cardiovascular disease, there is compelling evidence for association between hypertensive disorder of pregnancy and future cardiovascular disease, like hypertension, like ischemic heart disease, ischemic stroke, thromboembolic disease, heart failure, chronic kidney disease, diabetes mellitus, arrhythmias, and hypertension in adolescent life, even in offspring. Now, the contemporary recommendation, pregnancy history. The pregnancy history is integral component of cardiovascular risk evaluation for women. Women with prior preeclampsia, hypertensive disorder of pregnancy, needs an early intensive coronary risk intervention. We have to counsel them for because the cardiovascular risk is increased, and we have to consider the effectiveness of cardiovascular risk assessment and a reduction in primary prevention cardiovascular disease. So this changes the situation when there is in these cases. We have to screen women who have hypertensive disorder of pregnancy as early as 1 year postpartum. Guidelines, so there are guidelines which are needed for structured follow-up cardiovascular risk management after this pathology. Now, in perimenopausal, we have in women, we have a decrease in exercise, which is superior to the decrease in calorie intake, which we have afterwards a weight gain, the waist circumference, of course, increase in blood pressure. We have a decreased social interaction duration over time, which leads to mood disorders, sleep disturbance, vasomotor symptoms, changes in work patterns, stress, etc. This is the condition of women in this age. We have alteration in lipid profiles also. In postmenopausal women, we have dyslipidemia, hypertension, metabolic syndrome, lack of exercise, psychosocial functions, which need social support. We have mood disorders or dysphorias, a higher prevalence of stroke, which has to be taken into consideration. There are dispelling myths, confusion among women remains. Observational study reported that hormone replacement therapy is effective for symptoms and diseases cardiovascular and osteoporosis menopausal women. But there are two large randomized controlled trials, HERS and Women Health Initiative, that reported no benefit prevention of cardiovascular disease. The Women Health Initiative found increases in breast cancer incidence and cardiovascular events in healthy women. There is a Million Women study that shows an increase in breast cancer with hormone replacement therapy. Also, the dispelling myths, and which leads to confusion among women that remain. And so we have to remind women that hormone therapy should not be used for primary and secondary prevention of cardiovascular disease. And there are supplements which are not used in preventing cardiovascular disease, like vitamin E, vitamin C, beta-carotene, folic acid. Also, aspirin is not recommended for healthy women less than 65 years old. We have also health disparities among women. There is a higher prevalence of risk factors in racial ethnic group. For example, hypertension is more prevalent in Black women. Diabetes is more prevalent in Hispanic women. And we have additional socioeconomic factors, which is inadequate access to healthcare among the socioeconomic groups. And we have reduced access to fresh food and easy availability of fast food, which is a considerable problem. And there are these community characteristics which increase the burden of the healthcare for women, of taking care of women. The lesson from the field: women may be the key to changing health habit in minority communities. A message that resonates: take care of yourself so you can take care of the family. So a woman that because the woman is the center of the family. If she takes care of herself, all the family, it's contagious to all the family. And if you treat the woman, the family changes. That's what I was saying. Women need social support, especially in certain ethnic and maybe religious groups. So go where the women are. So churches, community organization, etc. So these are the slogans that have to be followed. Now this is the infographic for the public, which is important to raise so women are aware of. In this infographic, we see that what are the heart attack symptoms, the chest pain, the neck, or the shortness of breath, nausea, vomiting, dizziness, the different symptoms that are found in women. Also, so that we attract their attention if there is any symptoms. And there are risk factors, the risk factors that are unique to women. For example, we write on the infographics that many women experience no symptoms, and it's important to know the risk. For example, menopause, it's an important to do a check-up. If there are many ovarian cysts, if there have been high blood pressure or diabetes during pregnancy. Okay. Also, we put heart disease is the #1 killer in women, and it causes more women deaths than cancer, including breast cancer, etc. Okay, so this is a good infographic and others that play a role. Now, the American Heart Association created in 2004 a social initiative for women using the phrase "Go Red" as an acronym, which means G, get your numbers, ask your doctor to check your blood pressure and cholesterol. O, own your lifestyle, stop smoking, lose weight, exercise, and eat healthy. It's up to you. No one can do it for you. R, realize your risk. We think it won't happen to us, but heart disease kills 1 in 3 women. E, educate your family. Make healthy food choices for you and your family. D, don't be silent. Tell every woman you know that heart disease is our #1 killer. Okay, thank you very much for your attention.